Good morning. I'm Dr. Christina Ciaccio. I'm the Chief of Allergy at the University of Chicago and an Associate Professor of Pediatrics in Medicine. So this morning I am going to just kick off the topic of the pathogenesis of allergic disease, and I'm going to be followed by three absolutely fantastic speakers who are each going to dive into one of the hypotheses of why food allergy is so highly prevalent in the United States today. So I am going to talk about adverse food reactions with a slide that I think, all hold near and dear to our heart. Of course, for the sake of this meeting, we are going to be talking about immune-mediated adverse food reactions. And for the most part, I am assuming the following speakers are going to be specifically talking about IgE-mediated food allergy, and to a much lesser extent, non-IgE-mediated food allergies such as FPIEs, or things that may be non-IgE-mediated or mixed, such as EOE. So why do we care about food allergy? Well, we care because we know that children with food allergy and the families of these children have a decreased quality of life. It goes certainly beyond just the fear of a reaction or the reaction itself. But we know that children with food allergies are bullied. We know that family social activities can be negatively impacted. It becomes much more difficult to dine out and attend sporting events. Children's social activities also become limited. Accommodations are needed for playdates and birthday parties and camps that aren't needed for other children. And children require special food, and that food can be hard to come by. It can be extremely expensive, and it's not available for all populations in the United States right now, very unfortunately leading to a disparity in food allergy. And at times, children can be separated from their peers at mealtimes and during social activities because there is anxiety about an accidental reaction, which can be very isolating for the children. In one study, the quality of life of those with peanut allergy were compared to those with insulin-dependent diabetes. And what they saw was that the overall mean score was higher for peanut allergy, which means that the quality of life of those with peanut allergy was more highly impacted than those with insulin-dependent diabetes. The children with peanut allergy were more afraid of an accidental ingestion of peanut than children with insulin-dependent diabetes of having a hypoglycemic event, although both reactions can be fatal and can lead to a hospitalization. The peanut allergy group in this study had high anxiety at social activities, and they felt restricted in their physical activities. So why do we need to understand the disease development or the pathogenesis of this atopic condition? Well, if we want even a crack at being able to come up with preventive strategies or safe and effective treatment options, we need to have an understanding. But of course, the ultimate goal for me will always still remain finding a way to reset the immune system so we're no longer living with these chronic non-infectious inflammatory diseases, but getting to a state where children and adults with food allergy may be cured or may be in a remission or a state of tolerance or whatever that looks like or word you want to describe it, getting them to a place where it does not become a worry and they don't have to do anything special on a day-to-day basis to maintain the state of tolerance. What is the pathogenesis of food allergy? It is the failure of oral tolerance. And to better understand what food allergy comes from, we have to understand where oral tolerance is failing. So what oral tolerance is, it typically happens in the gut immune system. Of course, the luminal barriers are a significant player, as is the extensive lymphoid tissue throughout the gastrointestinal tract. And the key components include the antigen degradation that happens with enzymes as soon as food antigen enters the mouth, and as it goes into the stomach, it has additional degradation from the acidic environment. And then as it leaves towards the duodenum and small intestine, of course, the antigens are selectively taken up and presented to the immune system. The antigen presentation, of course, happens from CD103 positive dendritic cells, and then the effector cells, when oral tolerance goes correctly, will produce T regulatory cells in a high amount that keep the immune system in check and send overall a signal that this antigen should be tolerated and allergic reaction should not occur. So what are things that affect oral tolerance? Well, the nature of the antigen, the dose of the antigen are both very important. The frequency of administration of the antigen, The age at the first exposure we know, and the immunological state of the host at that time all play a critical role in oral tolerance. The dietary exposure that the mother has during pregnancy, as well as while she's breastfeeding, because we know antigens are transmitted via breast milk, and the route of first exposure and bacterial colonization all seem to be critically important for oral tolerance to happen correctly. So what specifically signals for oral tolerance? Well, the nature of the antigen. Soluble antigens tend to signal more strongly for tolerance, whereas particulate antigens do not. The dose of the antigen, as in a low dose versus a high dose, can make a difference. However, both low dose doses of antigen as well as high doses of antigen can signal for oral tolerance, but in distinct pathways. So the exact right dose at the right time, we still need to do work to figure out exactly where this is. Of course, with the frequency of administration of antigen, the more frequent exposure tends to lead to tolerance. And of course, this makes sense if you think of many generations throughout the time of humans. We would not have traveled to the extent that we do now, and we would not have been able to transport foods. So the foods that would have been available to feed to a child would have been in the close proximity of where they were born, and it would have been certainly a much more limited repertoire than what we have now. So children would have probably exposure to the foods that they were going to eat their entire life when they were very young, and they would have had eaten them frequently. Of course, the age at first exposure, we certainly know from the LEAP trial, seems to make a difference. The early exposure was highly significant in preventing peanut allergy, and I think studies continue to be on the way to see if other allergens, it's also effective technique. And of course, the immunologic status of the host. This food allergy is a chronic non-infectious inflammatory disease, of course, with skewing to the Th2 side of inflammation, but it is still a chronic inflammatory disease, and the host, the child's immune system, needs to be in a state of preparedness for the antigen when we introduce it. Of course, the dietary exposure of mother and the antigen transmission via breast milk is important because in this situation, IgG and IgA can be bound to the antigen and can be presented to the mucosal immune system in a way that directs it very clearly how it should be processed and can certainly be more likely to signal towards tolerance. And of course, the route of first exposure. So if it's extraintestinal, we worry very much about the loss of oral tolerance. We really want that first exposure to be through the mouth, where oral tolerance can be signaled and not through the skin, for example. And then, of course, more and more we have been thinking about bacterial colonization, not only in the gut, but throughout the child's body. And we are paying attention to both the gamma diversity and specific bacteria, namely those that are butyrate producing, as mechanisms for promoting oral tolerance. So several hypotheses have been proposed at why oral tolerance is lost. But what I would like to drive home this morning is that these hypotheses are not independent of each other. So there are many, but they can all be at play. They all signal a different part of a loss of oral tolerance, and certainly may all be a part of the big picture. So the microbiome hypothesis, of course, is one that we're going to hear more about today. It originally started in the 80s as the hygiene hypothesis, but the hygiene hypothesis, as it was originally written, fell apart fairly easily. But now that we've learned more and more about the exact bacteria that live in the gut, this has certainly become a viable hypothesis again and speaks to how we have co-evolved with bacteria throughout time. And these bacteria have been immunoregulatory for us. So the loss of the correct bacteria has led to inflammation that may lead then not only to a food allergy, but if genetics dictate, it also may lead to other chronic non-infectious inflammatory diseases such as diabetes. Of course, there's the omega-3 fatty acid hypothesis. In this hypothesis, briefly, it says that the amount of omega-3 fatty acids has been skewed since the 1960s very strongly towards a more omega-6 fatty acid rich diet here in the United States. And because of that, the omega-6 is more likely to produce arachidonic acid and lead to a state of inflammation in the host. Of course, that would cause a signal loss of oral tolerance. There's, of course, vitamin D hypothesis that says that we are certainly outside less, our vitamin D levels are lower. There's been some thought actually to low vitamin D and extremely high vitamin D exposure, both skewing the immune system and signaling a loss of tolerance. And a very important one that we're looking at now is the dual allergen exposure hypothesis. So this one says that if you have an allergen that goes through the epithelial barrier and is not presented through the mouth, then again, you can lead to loss of oral tolerance. Of course, the food processing hypothesis that we are processing our foods differently, we're growing them differently. An example of this would be peanuts, of course, which are boiled, we think are less allergenic than those that are fried or more allergenic, or in the case of shellfish, those that are boiled may be less allergenic and those that are fried may be more allergenic. And then, of course, maternal stress is a hypothesis that is gaining intense interest, particularly as we look more and more at the disparity of food allergy and atopic burden across the country. We can see that there are certain areas that are blighted and families have less access and increased stressors really just to get through day-to-day life. This is showing that it's significant to the immune system and certainly maybe something that is important as we think about the development of atopic disease. But all of these hypotheses, again, can work together because they all target a different part of oral tolerance. And it certainly may be that this is a multi-generational phenomena. And as things change, different parts of oral tolerance have been affected and we've come to this point. There's been too many hits and we have been left with this state of inflammation. So, of course, the microbiome hygiene hypothesis speaks to the bacterial colonization importance of oral tolerance. The omega-3 speaks to the immunologic status of the host, as does the vitamin D hypothesis. Of course, the dual allergen exposure hypothesis speaks both to the point of entry of the first exposure as well as the age and frequency of exposure. The food processing speaks to the nature of the antigen, and then, of course, maternal stress speaks to immunologic status of the host as well. So again, in combination, all of these things play a part in oral tolerance. They're all important, and I think as we move forward, we need to look to see if in combination we can get oral tolerance again to a place where we can prevent food allergy. Which of these pan out? So, of course, we look at genetics whenever we're talking about the pathogenesis of disease and food allergy. There's been certainly a gut instinct that there is a genetic component, and this has been shown by some great studies. One, a twin study of peanut allergy that included 14 monozygotic twin pairs and 44 dizygotic twin pairs. And they showed a 64% concordance in peanut allergy in the monozygotic twin pairs compared to a 6.8% concordance in the dizygotic twin pairs. This led to a heritability estimate for peanut allergy of 81%. So, of course, this is a strong genetic association. And then a sibling study of food allergy included 581 families and food allergy in one child. Diagnosis was based on clinical history and IgE level, predicted a food allergy in the other siblings with an odds ratio of 2.6. So what genes play a role? Well, we do know that there are some monogenetic disorders that are associated with food allergy to a greater extent than the average population. So Loeys-Dietz syndrome, which is associated with mutations in TGF-beta, DOC8, PGM3, Netherton's, IPEX, and Wiskott-Aldrich all have a predisposition to food allergy. But these genes, of course, these mutations are in a very small amount of population and hardly are an explanation for why the prevalence is so high across the United States. But when we look at GWAS studies, we can see some significant loci that seem to be affected, including SERPINB, filaggrin, HLA, a cytokine gene cluster, and LRRC32, of course, which is at the start of TGF gene. The first two, which play a critical role in the epithelial barrier function, so again speaks to the route of first transmission, and the latter three speak to inflammation in the host. All these are key components of the immune system, and with the mutations certainly may predispose the host on that first exposure to tolerate the antigen. But genetics alone does not seem to be the explanation or the whole explanation that can get us to where we need to be. We've watched the prevalence increase over the past several decades. In the case of peanut allergy in 1997, a phone survey estimated the prevalence to be 0.4, and as different methods, of course, can't directly be compared, were done, the estimate did seem to increase until very recently in 2015, 2016, a survey estimated a prevalence at 2.2%. So this same study said overall there was a 7.6% prevalence of convincing food allergy in children. Over 40% of these had experienced a severe allergic reaction, and the predominant foods were peanut, milk, and shellfish. But it wasn't just in children, it was in adults. And certainly, I think many people would have guessed decades ago that very few adults had food allergy. There's not a lot of data to compare this, but in the 2015-2016 study, they concluded that 11% of adults had a convincing food allergy, the most common of being shellfish, but greater than 50% at some time in their life had experienced a severe allergic reaction. So this increase in prevalence really speaks to the environment playing a strong role too. And there are many things that have happened in the past several generations that would influence many of these components of oral tolerance, including an increase in C-sections, a decrease in breastfeeding, an increase in simple sugars in our diets with a decrease in fibrous plants, an increased use of antibiotics, a large move from rural environments to urban areas, a decrease in family size, increased use of bactericidal soaps and detergents in the home, not only on surfaces but on skin, increased sanitization of the food we're eating, and certainly water contaminants. We're drinking city water more frequently than ever before, move away from well water. To exemplify this dramatic shift, I have found a picture that is not actually of my home, but this, from what I could steal on the internet, since I didn't have anything from home, this is actually very similar to the road I grew up on. And this is actually a photo of my older brother. In front of him is our breakfast table, our table we eat breakfast and dinner at, as a matter of fact. And this, of course, is our horse saying hi to him through the window as he's having a snack or breakfast one morning. My father came from a very large Italian family. There were 8 siblings in his family. Also grew up in a rural environment. And 2 generations later, this is actually a view from where I live now in the city. You can see in the background the university. So it's like I never leave work at all. But this is the environment my kids are growing up in, which is substantially different. We have a small family. I have 2 children, and we have very little green space to be outside. Of course, we do. We're very lucky in Hyde Park to have many trees, but in just 2 generations, there has been significant changes in just my family, all of which can have had a significant impact on the environment that my kids have grown up in. And so that brings us to some important hypotheses that are going to be discussed further in the next presentation. But the first is near and dear to my heart. It's something that I believe in as a potential for therapy with microbiome modulators, but it's the microbiome hypothesis. And in this one, again, it says that we have co-evolved with bacteria for millennia, and we have lost some of these bacteria, or it's certainly changed in composition over the past several generations. But what we want is to live in a symbiosis with these bacteria. So it may be things like an increase in prebiotics, so those fibrous fruits and vegetables that we eat, or potentially exploiting different probiotics can lead either to the colonization or the increase of beneficial microbes that will secrete postbiotics, such as the short-chain fatty acids, specifically butyrate, which then feed back to our immune systems and keep it under control by maintaining a nice tight barrier function and certainly influencing the immune system to a state of tolerance in a way from a state of inflammation. Another hypothesis that we're going to hear about today is the dual antigen exposure hypothesis. So we are certainly starting to think very strongly about a tight epithelial skin barrier function. And what we know is that as soon as eczema starts, there is a pathway for allergens to be introduced to the body for the first time instead of through oral tolerance. So kids certainly who have peanut dust in their floors and maybe active eczematous lesions on their arms if they crawl across the carpet, maybe getting antigen exposure in this way. There are probably other influences on the skin that can lead to the state of inflammation, but in general, if these allergens are introduced through the skin, the signal to the immune system is going to fight them instead of tolerate them. And we, I think, are going to be looking very intensely in coming years of whether there is a way to improve the barrier function of the skin to prevent the development of food allergy. And the last thing we're going to hear about is the gut-brain axis, and certainly very intriguing as a potential player in food allergy. We certainly know that both maternal and childhood stress is increasing, certainly in certain populations. And when we talk about this, we're referring to stress that is transmitted partially via cortisol from the central nervous system down to the gut nervous system, the enteric nervous system, and these signals can actually have some of the same effects that we see when we change the microbiome. We can see an increase in intestinal permeability and effects on motility as well. But this pursuit is certainly worth all the effort that we're putting into. We've had 2 huge successes in recent years, one in prevention and one in treatment, that has resulted from our understanding of oral tolerance and the pathogenesis of food allergy. One, of course, is the LEAP study that showed us that it's very powerful to get the timing right of introduction of a highly allergenic food, such as peanuts. And then, of course, just in 2020, we had our first FDA approval of a food allergy treatment ever. And this, again, speaks volumes to how we are influencing oral tolerance by the timing and the amount of introduction of an allergen. So my hope is that in coming years, we can expand upon this, that we can continue to bring new treatments to market with this knowledge we've gained, and certainly continue to work on preventive strategies. So there may be a point where we don't even need treatment for children any longer. And of course, with a long-term cure of having something for every kid who has a food allergy so that they can live the quality of life that they want to live. So with that, I just want to thank you very much, and I will turn it over to the team that is going to go in depth and talk a little bit about disease development. So thank you very much.